we will talk about the spleen. Spleen is also known as the organ of the mystery because it forms the blood, before the blood, it destroys the RBC after the birth, and it stores the RBC after the birth. And it is the largest lymphoid organ of the body. It secretes, it forms the lymphocyte after the birth, and it is responsible for forming the IgM from the plasma cell. And it is soft purplish organ. It is a soft purplish organ and is surrounded by a thin capsule. This thin capsule contains the smooth muscle cells in cases of the mammals. So if there will be the smooth muscle cells in this capsule, then what is the role of this smooth muscle? This smooth muscle squeezes the blood from the spleen in cases of the mammals. Regarding its external feature, it is located on the upper left quadrant of the abdomen. So we have got the 9 quadrants over here. So it is located in the upper left quadrant of the abdomen. It lies under the diaphragm. So we have got diaphragm over here. It lies under the diaphragm, and the Harris dictum, that is 1, 3, 5, 7, and 9, and 11. It summarizes its entire of the spleen. That means its thickness is 1, its breadth is 3, 5 is its length, weight is 7 ounces, with 150 grams, and it lies deep to the 9th, 10th, 11th rib. Its weight decreases with the advancing age. You could see that it is along the 10th rib, and it forming an angle of 45 degrees at the base. So if we have got the, we could see over here, that is the 9th rib, which is the 10th rib and 11th rib. So its upper border is along the 9th rib, its lower border is along the 11th rib, and its long axis passes along the 10th rib. Its center passes along the 10th rib. So the axis of the spleen is along the 10th rib. So it has got 2 ends. It has got 3 borders, 2 surfaces, 2 angle, and a hilum. So we could see over here, this surface is the diaphragmatic surface, and this surface is the visceral surface, and you could see the hilum over here. We have seen this is the inferior border, and we have this one is the intermediate border over here, and this one is the superior border. So we have 2 poles. This is the superior pole or the posterior pole, and this is the inferior pole or anterior pole. Inferior pole is anterior pole. That means liver lie along this much, means upper pole, if the superior one is posterior, and the lower pole is anteriorly. So it has got this border is the superior border, this one is the inferior border, and it has got an intermediate border along which the hilum lies. And it has got 2 angles. One is called the anterior basal, and other is called the posterior basal. So superior border forming the angle with the anterior end is known as the anterobasal, and the inferior border of forming the angle with the anterior end is known as the posterobasal. Now its lower pole does not normally project further than the mid-axillary line. So if we have the spleen is beyond the mid-axillary line, we could not expect this normal spleen to be in front of the mid-axillary line. So in this diagram, we could see over here, this one is the mid-axillary line. This one is the mid-axillary line. This one is the mid-axillary line. And the anterior end or the lower end of the spleen does not extend beyond the mid-axillary line. Its hilum lies in angle between the stomach and the left kidney. So we have got the kidney over here, and we have got the stomach over here. And here is the hilum of the spleen, and it is angle between the stomach and the kidney. It lies between the stomach and the kidney. Its angle, the hilum is facing towards the kidney and the stomach. Its anterior border is notched. Its anterior border is notched, and which relying upon that it was formed by several spiracles during the embryonic life. So we could see the notch over here. So this notch is present on the anterior border. This notch is present on the anterior border. So anterior border is notched. This anterior border is notched, and it means that several spiracles unite together to form this spleen. So it lies in the left margin of the lesser sac below the diaphragm. So we have got this diagram. We have got the peritoneum. This is the peritoneum. This is the visceral peritoneum over here. Here we have got the stomach, and this one is the lumbar vertebra over here. So this one is the left kidney. This is the left kidney. This is the lesser sac. This is the lesser sac, and we have got the greater sac over here. Greater sac over here, and this one is the porta hepatis. This one is the porta hepatis, and we have got this spleen over here. This is the right side. This is the left side. So you could see over here that this is the lesser sac, and here we have got the spleen, and this spleen is lying below the diaphragm, the left margin of the lesser sac. The visceral peritoneum invests all around it. It is being, you could see in this diagram also that it is being invested by the visceral peritoneum all around, except at the hilum. And the peritoneal reflection from the gastro. At this hilum, you could see that it is connected to the stomach and it is connected to the kidney also. See in this diagram that this is being connected to the stomach and this is being connected to the spleen also. We'll see in the later slides also. So now the two layers of the greater omentum, this two layer of the greater omentum passes from the hilum forward to the greater curvature of the stomach, and this will form. So we have got over here, this is the stomach, and here we have got the coming from the kidney, and we have got the lienorenal ligament over here. This one is the lienorenal ligament coming from the kidney to the hilum, and we have got the gastrosplenic ligament. It is coming from the stomach and going towards the spleen. So this one is the gastrosplenic ligament, and here we have got the lienorenal ligament. It's the lienorenal ligament is coming like this, and this forming the lienorenal ligament. So we have got the two ligaments which is being formed by the greater curvature of the from the hilum, passes from the hilum forward to the greater curvature. The stomach, this is the gastrosplenic ligament, and backward from the front of the kidney, it is going forward. This is forward, and this is backward. This is anterior, and this is posterior. So anteriorly it is going towards the stomach, and posteriorly it is going towards the kidney. The gastrosplenic ligament has short gastric branch of the left gastroepiploic artery. You could see over there, this is the short gastric artery, and the short gastric artery is going towards the spleen in this gastrosplenic ligament. In this gastrosplenic ligament, you could trace the short gastric artery which is moving towards the spleen from the stomach, and in the lienorenal ligament, you could see the splenic artery, the vein, as well as the tail of the pancreas. So, you see in this diagram that this is the lienorenal ligament, and this linear ligament contains the tail of the pancreas. This is the tail of the pancreas. Then it also contains the splenic artery. We have seen, you could see the splenic artery over here. So splenic artery is also traveling through the linear ligament. So the linear ligament is very important as it contains the splenic artery. Of course, whenever there is artery, there will be the vein. So it contains the splenic artery and the splenic vein, and the most important, the tail of the pancreas. So removal of the spleen, whenever do we do the removal of the spleen, splenectomy, it is essential cutting two pedicles of the splenorenal and the gastrorenal ligament. So remove the spleen, it will be essential to remove this one and this one, but we have to preserve the tail of the pancreas. We should cut beyond the tail of the pancreas to protect the patient from becoming the diabetic. On the fold of the there is a phrenicocholic ligament. This phrenicocholic ligament is over here. This is the colic, this is the colon, and here we have got a ligament over here, and this ligament is going towards the diaphragm. It is going towards the diaphragm. We have got a diaphragm over here. We have got a diaphragm over here. We have got a diaphragm over here. To the thoracic diaphragm opposite the 10th and 11th rib. So opposite the 10th and 11th rib, it will go towards the diaphragm. We have got the diaphragm over here. We have got the spleen over here. We have got the colon over here. And so it will go like this. This will go like this. This phrenicocholic ligament. We have got this is a colon over here, and this is the phrenicocholic ligament. It will go from the colon to the diaphragm. We will go to the colon to the diaphragm, and it passes below the spleen. It passes below the spleen. It will pass below the spleen, so it will support the spleen, and that's why it is also known as the sustentaculum lenis. So in this diagram, we could also see that here is the phrenicocholic ligament going from this colon to the 10th and 11th rib around about, and this is supporting the spleen at the lower end. We support the spleen at the lower end. And in this diagram also, we could see that this is the phrenicocholic ligament. Phrenicocholic ligament traveling from the colon up to the diaphragm opposite the 10th and 11th rib, and it supports the spleen at the lower end. So its concave visceral surface is oriented towards the other abdominal organ and present the impressions of the gastric, renal, colic, and tail of pancreas will be seen at the hilum. Tail of the pancreas will be seen at the hilum. So in this diagram, you could see that this is this opposite surface is the diaphragmatic surface, and this surface is the visceral surface. This is the visceral surface. Above one, this one is present. This is the gastric surface. Lower one, we have got the renal surface, and at the anterior end, we have got this is only the colic surface. This is only the colic one. So we have got the gastric surface, we have got the renal surface, and we have got the colic surface. This is all present, and at the hilum, we will see the tail of the pancreas. At the hilum, we will see the tail of the pancreas. So we have seen the impressions. Now its lower inferior pole is related anteriorly and colon posteriorly and left side kidney. So colon will be posteriorly, inferior pole is, is related anteriorly. We have seen that the superior pole is posterior and inferior pole is anterior, and colon will be seen on the posterior side. The colon we have seen on the posterior side. The small colic area lie in contact with the splenic fixation of the colon and the phrenicocholic ligament. So this colon is lying in relation with the spleen, and the most important is the phrenicocholic ligament. The hilum of the spleen makes the contact with the tail of the pancreas, which lie within the splenorenal ligament. And the hilum, we have seen that tail of the pancreas is related to the hilum. Now, regarding the enlargement of the spleen, so in some disease, the spleen is grossly enlarged and extend across the upper abdomen beyond the umbilicus toward the fossa. So, when the spleen enlarges, it goes like this. It reaches the right iliac fossa. It will go towards the right iliac fossa. So, it will move like this. So, it moves in the direction of the umbilicus, and anterior border approaches the costal margin. Anterior border will approach the costal margin, and kidney is enlarging downward in the direction of the iliac fossa. The spleen to be palpable, this one is the normal size of the spleen, and this is the enlarged spleen. To be palpable, it must be of double size. 150 gram is normal weight, so it could be of 300 to 400 gram. Then only it could be palpated. A palpable spleen is identified by the notch on its anterior border. Its notch on the anterior border, that will be identified. It will be identified the notch which is present on the anterior border. By virtue of that, it will be identified. Now, differentiation with the renal tumor. The renal tumor is, number one is the retroperitoneal. Renal tumor is retroperitoneal, and renal tumor goes like this. It will go towards the left iliac fossa. It will not move towards the umbilicus. It will go towards the left iliac fossa. Number 3. Number 2. In cases of the renal tumor, when we do the colic percussions, then we could see the resonance of the colic resonance could be felt in case of the renal tumor. But in cases of the enlargement of the spleen, we could not see the presence of have the resonance of the colon, because this colon remains posterior. Its colon remains posterior, and this moves anteriorly. So the colonic resonance is absent in cases of the splenic enlargement. It goes above the colon, and colon could not allow it go in front of the spleen. So how to hold the spleen in the hand in the practical classes? So the upper end of the anterior end should be the thumb at the thumb. We should hold it thumb, and the lower pole should have at the little finger. Diaphragmatic surface of the detached organ in the hollow of the left hand. Diaphragmatic surface will face the hollow up and rotating in until the notched anterior border lie in front of the thumb. So notched anterior border, you could see over here, is the notched anterior border. This notched anterior border should face the thumb. The concavity between the notched anterior border and the hilum is the gastric impression. So between this one and the hilum, this will be the gastric impression. Behind the hilum is the concave renal surface. This one is the concave renal surface, and the lower pole is the at the tip of the little finger, we have got over here the colonic impression. This we have the colonic impressions. So anterior border should face the thumb, and the lower pole should face the little finger. Between the anterior border and the hilum, we have got the gastric impression. Between the hilum and the inferior border, we have got the renal impression. And at the anterior end, we have got the lower polar end, we have got the colonic impressions. Now, spleen develops. We have got this. We have got the stomach over here. This is the foregut region. This is the midgut region. And this is the midgut and hindgut region. And we have development of the liver over here. This is the stomach, and we have got the spleen over here. This is the spleen, and we have got the kidney over here. This one is the falciform ligament. We have got the lesser sac over here. We have got the greater sac over here in this. This ligament is the gastrosplenic ligament, and this one is the linorenal ligament. Spleen begins to develop in the fifth week as a several condensation of the mesodermal cells in the dorsal mesogastrium. This is the dorsal mesogastrium, and this is the ventral mesogastrium. So it develops by the fusion of the small mesodermal cells. Since because of the splenic presence, the dorsal mesogastrium divided into splenorenal and the gastrorenal ligament, which you have seen over here. Spleen thus come to lie at the left margin of the lesser sac, which we have already seen. That this is the lesser sac, and it is on the left margin. The original condensation, if some of the cells fail to fuse completely, this causes the presence of the notch on the anterior border. This incomplete fusion presents with the notch on the anterior border. So this is the spinnucles. We could see the incomplete fusion, and this incomplete fusion causes the presence of the spinnucles. Now there are single or multiple accessory spleen. Accessory spleen are the result of lack of fusion. If there will be no fusion, then we could have the one or several spleens, and this could be usually along the splenic vessels, or in the peritoneal attachment. We could also see in up to 20% of population. Rarely it is of 2 centimeter diameter. This accessory spleen could be of 2 centimeter diameter, rarely in 20% of the cases. Where you could find the abnormal spleen, we will find at the hilum of the spleen. This is the 50% highest chances. Near the splenic vessels, with the artery, we could have the presence. We could have in tail of pancreas. We could have in the splenic ligament, in the mesocolon, and the gastric meso-omentum. Regarding the blood supply, it is being supplied by the colonic trunk, which is tortuous vessels that give the multiple branches to the pancreas, and it travels along the posterior aspect. You could see over here. This is the celiac trunk, and from the celiac trunk, this is the splenic artery. This is splenic artery is along the upper border of the spleen with the pancreas, and it is moving towards the spleen. The splenic artery passes between the two layers of the splenorenal ligament, which we have already seen. At the hilum, we divide into 2 or 3 main branches, from which the more branches enter the spleen. So you could see that it is dividing into 2 or 3 branches, and from there, the multiple branches will enter into the spleen. Regarding the veins, the vein accompanies the artery, which we already know that this is the splenic vein. This is the splenic vein traveling along behind the pancreas, and just behind the neck of the pancreas, this splenic vein will unite with the superior mesenteric vein to form the portal vein. This will unite just behind the neck of the pancreas, and they will form the portal vein. Regarding the blood supply, there are 2 theories. One is the open theory and another is the closed theory. Open circulation theory proposes that the blood empty into the marginal zone and red blood cords and travel through the cavernous sinuses and finally re-enter through the vasculature to re-enter into the endothelial cells. So this one is the open theory. This one is the open theory. The open theory is the blood coming from the trabecular artery and it is going outside and it re-enters to the endothelial side slits, the endothelial slits over here, and it will re-enter over there. Regarding the closed concept, it entails the continuity of the endothelium from artery to the sinus. See, in the closed continuity will be there from endothelial artery sinus. This one is the closed one. This is the closed one, and it is going like this. It will go like this. There will be no breakage. There will be no outside. It will not come outside. Now, finally, the splenic rupture. So, patient with the shock, pallor, hypotension, headache, tachycardia, and restlessness will be present. On examination, there will be tenderness and abdominal rigidity on the left upper area. It could be differentiated by the presence of the Kehr signs, which will have pain in the left shoulder 15 minutes after the foot end elevation. After, in cases of the diaphragmatic injury, immediately there will be the presence of the pain on the left shoulder region. Why? Because this pain is not due to the splenic injury. This pain is due to the irritation of the diaphragm, which having the phrenic nerve, and the left shoulder region having the same value, so C3, C4, and C5, and this will causes the pain on the left shoulder region. So clot collected under the left side of the diaphragm, irritate it, and the phrenic nerve causing referred pain in the left shoulder. So in case of the CT scan, you could have the spleen over here. So the left flank does not shift as the collected blood gets clotted. So dullness without shifting is the balance sign. So we will have the balance sign, and the balance sign is the dullness in the left flank which does not shift as the collected blood gets clotted. It immediately this blood will get clot, and so it will not shift, and this is known as the balance sign, which is the cardinal feature of the splenic injury. Thank you. We finish this day.